Hello, this is Dr. Margaret Elizondo with Sharp Hospice Care, and it's a pleasure for me to speak to you today on how we can help patients who are terminally ill navigate their final journey in our healthcare system. I've been a physician with Sharp Hospice Care since 2011, and for nearly 2 decades before that I was in family medicine, and I did a lot of hospital work that led me to the comfort care field. Our hospital system in the United States is not geared to coping with mortality. Our healthcare system needs to find a better way to support patients and families who are terminally ill, and education like this is the first step. The topics we'll cover today start first and foremost with communication, how to make sure that you are getting crucial information across to people who span a wide swath of educational levels, cultural backgrounds, and spiritual traditions. We'll go over a bit of the biases in our healthcare system, which make it difficult for people to come to their own decisions about what is right for them. We'll talk about who decision makers can be, what legal documents they can use to help in decision making and advanced care planning. We'll go over the barriers that people find to transitioning to comfort care at the end of life, and the signs and symptoms of terminal illness, which make it easier to understand where people are along their trajectory. We'll go over the history of hospice and palliative care, who's eligible for that, who pays for that, and how your anticipatory guidance and some role playing we can practice with can plant seeds for the future so that people can make the right decisions for themselves. Finally, we'll go over practical knowledge regarding medications and other things that can be used for comfort care, including alternative care pathways at the very end of life. The most important thing to start with is good language and communication skills. And it's really important that this be culturally sensitive. We are a global melting pot in the United States, and it's really important for us to figure out what the family dynamics are for our patients, whether they come from an individual versus collective support system, which might really impact how much information they want to know, who they want to share it with in their family, and who they want helping them make decisions. We have to be a little careful, though, not to assume that because someone is from a particular ethnic or cultural background that they will think a particular way. Recent immigrants may think about our healthcare system very differently than people who are more acculturated to the U.S. system. And so we really need to speak to people about what works for them and ask them questions rather than assuming that they will choose certain pathways. Spiritual input is important for some people as well, and we need to make distinctions between someone's own personal journey versus their family traditions. There may be clashes there if someone has a particular spiritual background and that is not shared by their family. If you are in a place where you have the availability of spiritual care counselors, please use that. It's interesting to find out how some people have beliefs or fears about what they can or cannot make decisions about regarding healthcare and end-of-life care in particular, and they may not have accurate information even about their own faith tradition, and a spiritual care counselor or chaplain can be very helpful there. And finally, try to set realistic goals with people. They may be very off on their understanding of what is available or not available, or realistic or not in terms of their expectations for cure with their healthcare problems. So we need to take into account their level of literacy and understanding and try to make sure that they are understanding us when we explain things that are happening to them. People's familiarity with the death and dying process can be absolutely nothing to having a lot of experience. It's important to find out what people's values and wishes are, although for people who have no experience whatsoever, sometimes they don't even know what it is that they really want. So it's important for us to offer our understanding of what's available to them so that we can support them in the best ways possible. As I said before, our healthcare system has its own biases. We are taught to cure at all costs. Comfort is not top of mind, even if that's what patients are seeking. The presumption is if you come to an emergency room that you want everything done to stay alive, even if the patient really just wants more comfort care in their final days or hours. We use loaded language even when we think we're offering people options for things such as CPR. I've heard people say, if his heart stops, do you want us to bring him back? Versus when his heart stops, would you like us to let him go peacefully? Because when you explain the actual CPR process to most patients and their family members, it's not something they would want in someone who's already terminally ill. We also have options of artificial hydration and nutrition, which usually are not helpful to people in their final days or weeks of life. These things are not comfort care. You risk pulmonary edema when you keep doing IV hydration in people when their organs are shutting down, and you risk aspiration pneumonitis when you artificially tube feed people, even though there's a misconception there that somehow you're going to avoid aspiration if you feed someone through a tube rather than through their mouths. And I have heard my own colleagues say things like, you can't let her starve to death. And it's not helpful to family members when we say things like that versus saying that we can keep her comfortable as she dies naturally, and reminding them that dehydration in the terminally ill is often peacefully sedating, not painful. Dehydration may be very uncomfortable in young, healthy people, but it is the natural process in people who are dying, and it's not something that we need to try to overcome with artificial means. We also have a lot of concern from patients and family members about narcotics like morphine. They are concerned that they're going to hasten death, and they might have, history of seeing someone die soon after being given morphine in a comfort care arena. But we need to remind people that we're giving medications to ease suffering, not to hasten death. Morphine is given when people are terminally ill already and have symptoms of suffering, where our goal is to relieve their suffering. Its use occurs with the dying process. It's not causing the dying process when it's used appropriately. When it comes to decision making at the end of life, it's important to know who's going to be making decisions and at what point. Very few people have done the advanced care planning to legally designate someone to make decisions for them. And we know that sometimes families are not always aligned with patient wishes, either from their own inability to let go or from financial entanglements or spiritual disagreements in the family or complicated relationships, not only amongst family members, but patient relationships to the healthcare system and what their experience has been in the healthcare system so far. The End-of-Life Option Act is another thing available recently in the past several years in California, which gives people who still have capacity to make decisions an option to take medications to end their lives at the time of their own choosing. And this can be fraught with problems for family members who may not be in alignment with that. There are a number of legal documents available for people to express their wishes ahead of time regarding health care at different times in their lives. In California, we have an advance directive that includes both a living will portion, it's what it used to be called, where you could write down what your wishes are for certain types of care in certain types of situations, although it's really hard to anticipate all the scenarios that might come up in the future. So you also have the option to choose an agent, your durable power of attorney, to make decisions for you if you're no longer able to. And people often will choose their spouse or significant other to make these decisions, and you can even do that verbally at the bedside if you don't have a document available or you haven't filled out one before. California does recognize a verbal request to have someone else make decisions for you. I do need to tell you about an anecdote from my own private practice regarding choosing your spouse as your agent to make decisions. And it often seems that I have wives who say they couldn't choose their husband to be their power of attorney for healthcare because they would never let them get off machines and would keep them alive forever. Though it seems that the husbands tell me that they wouldn't choose their wives to make decisions for them because their wives would pull the plug too soon. So even using a little levity like that to broach the subject of death and dying can make it easier to communicate with your patients about what they would or would not want done in certain circumstances. We also have best used for people who are in their final years of life, although there's no actual stipulation on this, a physician order for life-sustaining treatment form, which is an actual physician order where you can request not to have CPR done, not to have certain invasive things like artificial feeding done. It is best for people who want comfort care, because if you want to have CPR and go in the ICU and have everything done, which is our default in the system, you really don't need a POLST form. But the POLST form does let you choose, full treatment, full cares, although a physician's signature on it is supposed to mean that you are designating that this is both appropriate from the standpoint of what the patient wants, but that it's also medically appropriate. And for our patients who are terminally ill, it's not appropriate to continue to offer things like CPR, which is not going to be beneficial and not going to be effective. And so physicians don't have to follow the request by a patient to have everything done at all costs. You do have to take into account what's medically appropriate. When we get to the point where we realize we really do need to transition to comfort care measures because people are terminally ill, there are a huge number of barriers to this transition, both from the patient and family standpoint as well as healthcare provider standpoint. There are a lot of fears regarding the loss of life, of course, the suffering that goes along with that. People who are inexperienced with the dying process can feel especially helpless and not know what to expect. People are fearful of giving up too early, both family members giving up on their loved one who's dying and patients giving up on their family and losing the fight. Our cancer care treatment especially is filled with this war language where people are supposed to be fighting to stay alive, and we talk about people losing the battle, and as if we have choices over all of these things, and we really don't. If you are terminally ill, we really need to find a way to support people there and not feel like they have failed. And when it comes down to the nitty-gritty of using medications for comfort, people have concerns about addiction to things like narcotics and benzodiazepines. They are worried about our hastening death, and they're also worried about things like allowing death. We've really taught people that they should never, die of an infection, that there are antibiotics to treat these things, that there are certain things you're allowed to die of and certain things you're not allowed to die of, whereas we know that dying of things like pneumonia is a very common way to go with certain disease entities like dementia, and it is normal to die with an infection, and it's not a failure of the patient or the family member or the healthcare system in that regard. Deciding when people are terminally ill is fraught with a lot of indecision and questions for patients and family members as well as healthcare providers. We have a very splintered healthcare system, and people tend to be very subspecialized when it comes to medical providers. No one wants to be making the decision that we've reached the end of the road in terms of therapeutics for treatment. And medical providers need reminders as much as patients and family members that we have gotten to the terminal phase of life. When people are repeatedly hospitalized, that should be a red flag. When people are getting recurrent infections, as we mentioned before, there's this expectation that we have to treat every infection out there, where we know that when we keep giving people antibiotics, we can create other problems such as C. difficile colitis or antibiotic resistance. And we forget that an infection can be a blessing for the terminally ill. There was the old saying that pneumonia is the old man's friend, that these are common ways to go, and we need to remind patients and family members that this is normal. And that at some point we do not need to worry about keeping someone's blood pressure under good control, their blood sugar under good control, that we can back off on giving them medications that they thought they had to take for life. We don't necessarily need to lower their cholesterol until their dying day. And even when we think that we are preparing ourselves for the end of life, when we've gotten to, say, the palliative chemo treatment stage in cancer treatment, that palliative chemotherapy is not just a stopgap measure until we find another treatment and then another treatment. It should be the time where people are preparing for no treatments working at all. And this is where you bring up people's bucket list items and have them reprioritize what's most important to them. There's a big disconnect between what physicians think they have told the patients and family members about where someone is in their disease process versus what patients and family members have actually taken in. And it usually requires multiple conversations for people to understand where they are, especially if people seem to, quote unquote, bounce back temporarily, at least, from hospitalizations and seem to do a little better for a time with rehab. But if people really look at the long-term trajectory and see that every time mom goes into the hospital for another pneumonia, she's got a decline in her functional status. People become, wheelchair bound and then bed bound. And these should be things that we can advise people ahead of time that are clues that people are in their final stages of this illness. If people have unintended weight loss, all we tend to think about is how can we fix that? Can we put a feeding tube in? Can we give them nutritional supplements? Some of these things are contraindicated when people have terminal illnesses like dementia. We know that feeding tubes don't stop them from getting pneumonias. They actually can increase their rate of pneumonias. They also don't fix chronic pressure wounds and things like that from people being in bed. This artificial nutrition can delay death a little bit, but we need to remember, are we prolonging someone's life in a healthy way that gives them good quality of life, or are we just prolonging the dying process and actually increasing their suffering along the way? When people need custodial care in a nursing home, and they're beyond the point where they're there on those skilled days to try to rehab and get their strength back. When they're there custodially and are not expected to rehab at all, the average lifespan for those people is about 2.5 years. So you would think that at that point, nursing homes would be really good at preparing people for what's to come, and that in the next couple of years we would expect a loved one to eat less and engage less and walk around less, sleep more, and that would be an opportunity for us to prepare ourselves for the dying process. But unfortunately, our nursing homes are not set up for that. They still don't want people dying there. They tend to send them to the hospital to do that. Unless you've got hospice on board right at the nursing home, then it makes it a little easier for our system to accept the death and dying process. So next we want to talk about what hospice and palliative care really are and how they do help people with the dying process when people are terminally ill. We provide palliative care all the time. This is what is making sure that there's some comfort that goes along with invasive treatments and operations, etc. Hospice care is a specialized type of palliative care that we provide in the final months of life. So all physicians provide some palliative care because they're going to give you things that make you feel better. Sometimes the palliative care will be things like antibiotics that fix an infection that's uncomfortable. Sometimes the palliative care is pain medication that helps a temporary pain while your body heals itself, or while your body is healing itself from a procedure that was done. But palliative care, as we talk about it in the hospice realm, is generally for people who are in their last couple of years of life, and is really focused on deciding how much traditional care do we keep doing and how much do we transition to really focusing on what's comfortable. The payment system is easy for hospice care. There has been payment by Medicare for about 40 years now, since 1982. And Medicare pays for hospice care across multiple settings, whether inpatient or home care or in a nursing home. But palliative care, it doesn't have a good payment mechanism. And you can find some palliative care services in an inpatient setting, but far fewer of them in a home setting. And we're finding that people could really benefit from palliative care ahead of time because it is part of our anticipatory guidance for people who have chronic illnesses and are getting into the terminal phase on how they can prepare themselves so that we don't have such a late entry into hospice care. Because even though hospice care is for anyone who has a less than 6-month prognosis based on our best judgment, most people still don't get into hospice care until they're in their final weeks of life. And part of that is the perils of predicting prognosis. People don't like to commit to saying someone has less than 6 months to live, and we really don't know very well. But Medicare does have a list of guidelines that people can look up to decide when somebody qualifies for their hospice payment system. And we have plenty of people on hospice, especially the ones with the dementia diagnoses, who go on much longer than 6 months, but we can keep recertifying them and they can keep getting their hospice care well beyond 6 months, as long as we list the indicators that make us think that there's more of a chance that they won't be here in another 6 months than that they will be here. We use something called the surprise question for people who aren't as well versed in hospice and palliative care, and we ask physicians, would you be surprised if this patient was dead this time next year? Would it surprise you if they didn't make it to next year? And if that physician would not be surprised that they were gone next year, then there's a very good chance that they would qualify for hospice care. There's a lot of need for patient and family education, as well as medical team education. People are concerned that if they choose hospice care too early, they're going to be put on a morphine drip, and that's all that hospice does. And we need to re-educate them that we have plenty of people on hospice care who are still independent in their own homes, maybe still driving and taking care of themselves, but we know that they have a diagnosis that has reached the point where their life expectancy is short. And though they may be doing well now, we wouldn't be surprised at all if they took a steep decline any day or week, and certainly we would not be surprised if they weren't here in the next 6 months or the next year or so. The medical team also needs as much education as well. Very few are well trained in hospice and palliative care during medical school. That's just not where the priority is. The priority is in learning how to treat things, and leaving the not treating things to people who are clearly terminally ill, to everyone who's around, and where you don't need any expert to tell you that this person is going to be gone in a few days or weeks. There are people who are worried that hospice care somehow shortens lives. There have been a number of studies done that show absolutely no decrease in lifespan compared to expected course when you use traditional treatments, and there have been some very interesting studies that have actually shown longer lifespan on hospice than with some of the traditional treatments, especially when it comes to some traditional cancer treatment. So hospice care definitely does not shorten one's life, and the medications we use do not shorten life. They are used for people who already have a very limited lifespan, and we are wanting to reduce their suffering. Dementia is another area where choosing hospice early may well increase lifespan as you avoid hospitalizations, which are fraught with dangers for the elderly, especially the elderly demented patients, because you have delirium as a very common symptom when elderly patients have to change care settings. They become very confused, and that in and of itself is a factor that adds to mortality. So how do we guide people through this territory that is fraught with a lot of misinformation and poor decision making? One of the first things that I do for everyone is to normalize death and dying. That we are all mortal. This is not a failure of our medical system, of the patient, or of the family members involved. All of us must die. All we want to do is make it a process that is fraught with less suffering, less fear, and make it a comfortable process as much as possible. People need to know what might be coming down the road, even though many healthcare providers think that they have communicated well that someone's terminally ill. It doesn't mean that we've communicated well what to expect. So we can give people actual scenarios of what might happen so that they can contemplate decisions in advance. Something like a patient who's intubated on a ventilator in the ICU, and we know this is someone who didn't want to stay on machines long term, we can ask family members in advance about whether they want to make a decision about something like a tracheostomy before it's the time to do it right now. So when we know that we don't keep people, with endotracheal tubes in place for weeks at a time, and they're not recovering within a few days for us to think we can get them off a ventilator, we should be telling loved ones ahead of time what we expect to happen so that they know if we don't do this by this date, we would be offering a tracheostomy next. If you know that's something that he wouldn't want, we should talk about how we could transition him to comfort care now. There are things like our dementia patients we mentioned who get admitted to the hospital repeatedly for pneumonia. Rather than saying if she gets pneumonia again, we can say when she gets pneumonia the next time, would she want to come back to the hospital and be treated again with antibiotics, which might give various side effects? Or would she want this pneumonia to be the thing that would take her naturally at home? Because we can keep her comfortable while that happens. It doesn't have to be a painful process for her. We know how to treat that suffering, and she doesn't have to come back to the hospital again. Because it's not a matter of if, it's a matter of when. And things like artificial nutrition and hydration, if we can anticipate that this is something we're going to offer in the future, talk about it ahead of time. When we see that they've lost weight and we think that the next thing that would be offered would be these modalities, we can say if he can't eat enough on his own, would he want a feeding tube? Or do you know that that's something he never would have wanted? And we can let nature take its course, because it is normal for people to lose weight and eat less and drink less at the end of life. And we can take care of that in a way where we focus on comfort rather than focus on what the scale says in terms of his weight. When it comes to the common medications that we use for comfort care in hospice in particular, we need to do some education for patients and families about the types of medicines used and what they're used for and how we actually give them. We often use very concentrated oral liquids so that we don't have patients needing to swallow pills when that becomes difficult for them, and we can get a lot of medication into a very small quantity when they're having trouble keeping anything down, and can provide comfort care without having to go into the hospital to get an IV placed. We can even use subcutaneous routes for many medications, which means we can maintain that quite easily in the home, more easily than a peripheral IV. And there are a number of medicines that can be given by that route and can be less painful than maintaining and replacing peripheral IVs on an ongoing basis. The big three for symptoms that we treat recurrently in hospice care are pain and dyspnea and agitation. And we'll go over on subsequent slides the details of certain medicines we'll use for certain entities. But one of the things I wanted to delve into a little further was agitation in particular. So there can be so many underlying causes of that. Anxiety, hallucinations, pain can all give agitation, but would be treated with different medications or even non-medication modalities. And we also want to make sure we're not missing something like bowel or bladder issues such as constipation, which could cause agitation, or urinary retention, so that we know if we need to focus on giving a suppository to get rid of constipation or putting a Foley catheter in for urinary retention rather than covering up the agitation with medications. So next slides we'll talk about some of the specifics of these options. In addition to the symptoms I talked about on the previous slide, people who are going through the dying process may exhibit a number of these other changes. Social withdrawal and change in level of consciousness, maybe staying in bed more, spending more time sleeping. These are very common things that we want to educate families on, because people often will also eat less, sleep more, stop drinking. It's very important to teach the family that this is okay, and that people who are having trouble swallowing or aren't alert enough to swallow safely should not be force-fed things that could end up leading to aspiration and make people even more uncomfortable. It's important to teach families other ways to show love besides feeding them, holding hands, giving massage, listening to music, reading to people. All of these things can be incredibly therapeutic, and for some people decrease the need for other symptom management with medications at times. As we talked about before, urinary changes can be a problem and lead to symptoms, and we need to let people know that it might not be uncommon that people will lose control of their bladder and bowel. They may need to have a diaper on for safety. They may need to have a Foley catheter placed so that they're able to pee, or if they have skin issues because of having to wear a diaper, it may be better to have a urinary catheter in place so that their skin can stay dry. And people may have confusion or hallucinations, which may have to do with the dying process and part of the dehydration process, or may have to do with the disease process of entities such as dementia or cancers that may have brain metastases, or liver metastases where there's liver failure, rise in ammonia level, and if people are warned ahead of time that these things may be coming and that we have ways to treat these things, it might lead to fewer emergency calls and panic on the part of patients and family members where they end up in the hospital again. And we want to stop that at all costs, because that's rarely helpful to people in terms of avoiding suffering and getting the optimal comfort care. Restlessness and agitation, as we spoke about before, could be related to bowel or bladder issues, could be related to pain. And sometimes we don't know exactly what it's due to, and we might just need to try medicines and find out what works for patients best. So we also need to educate family members that we don't always know exactly what's going on, but we do know some of the things that can be helpful in terms of making people feel more comfortable, and we want to work on having those options available for them to use when needed. In the very final stages, last days or hours of life, we might see vital sign fluctuations. People may have breathing pattern changes. People may have fevers. It's important to educate families that just because someone has a fever doesn't mean that they have an infection and have to have a big workup and have to find out where that fever is coming from and have to give them antibiotics. No, what we want to do is make them comfortable. So if they have a high enough fever, it would be appropriate to give them a fever reducer, a cold compress, make the room cooler, take off some of the blankets. That's as much of a treatment for fever at this point in the game as doing a full workup to try to figure out where it's coming from and make sure there's no infection that must be treated. Pain and breathlessness are probably the most common things that we see at the end of life, no matter what someone's diagnosis is that makes them terminally ill. So these are the first things that we're going to talk about with the medications that we use in the subsequent slides. Medications for pain. Well, this is where we get into a lot of scary territory for many patients because we do use narcotics like morphine or others. Could be hydromorphone, Dilaudid, or oxycodone. And these things are used often because they help both pain and dyspnea. And it's really important to educate families on that too, that the breathlessness that people can get can be helped greatly by narcotic pain medications. Not everybody does better with oxygen or positional changes, although you can try that as well, especially with certain diagnoses. But our narcotics are our go-to for pain and dyspnea when people are terminally ill. Things like hydromorphone and fentanyl, when we're using things parenterally, either IV or subcutaneously, might be the preferred agents when we're dealing with renal failure. We often use fentanyl as a transdermal patch. It's a little less available in other modalities when you're outside the hospital setting, but it can be helpful, especially in renal failure. In some cases, we'll still use morphine even in renal failure. It does tend to have a metabolite that builds up a little more, but again, if that's what's helpful for patients for their symptom management and they're in their final days of life anyway, it's not really important that you are so concerned with whether someone has renal failure or liver failure, but it might give you some idea of what doses of medicines may be needed or not based on the medications you're choosing to use for a symptom. Now, pain comes in many forms. The narcotics are good for all types of pain, but they're especially good for somatic pain. And families get worried about using things like morphine. They've heard about it. They're worried that it's going to kill their loved one because they're sure that, grandma was doing just fine until that hospice nurse gave her morphine and then she died 2 days later, forgetting that, of course, we only used the morphine because she had some symptom of suffering that the morphine would be used for, and so she wasn't just fine before the morphine. She was terminally ill and suffering, and the morphine helped relieve her suffering while she died in a natural process for that disease entity. Some people want to stick with things like Norco, which is hydrocodone, rather than using morphine because they think that that's sort of a narcotic light. But the fact is, hydrocodone is equivalent milligram per milligram to morphine when given orally. So it is not a safer narcotic or a lighter narcotic than using morphine. And the problem with it is that hydrocodone only comes in formulations that include Tylenol, which can be helpful for some people, but it does limit the dose that you would give because the very high doses of Tylenol are toxic to the liver potentially. So we want to make sure that family members are getting the right information and encourage them that the morphine can be safe and effective when used properly. So as I said, there are different types of pain, and somatic pain is the first thing we would tend to use narcotics for, but there are other types of pain like neuropathic pain or bone pain from metastatic disease with certain cancers that might be helped by other specific types of pain medication. Both methadone and gabapentin are helpful for neuropathic pain, and some people have very little experience with methadone. It is a little bit of a messy drug to dose and work with, but used in relatively low doses, it can be really, really effective for people who have nerve pain and actually let them use less of traditional narcotics like morphine. Methadone is a type of narcotic itself. The great benefit that it has in hospice care is that it is one of these medicines that is absorbed directly through the buccal mucosa right in the mouth. We think of the liquid medicines we put in the mouth as being absorbed there, but most of them are not. When you put the liquid morphine or liquid oxycodone in there, or you put liquid lorazepam in there, one of our benzodiazepines, it actually is slowly trickling down the throat and being absorbed in the stomach and beyond. But methadone is a lipophilic medication that is absorbed right through the membrane in the cheek and gets into the bloodstream very quickly and can be very helpful for nerve pain. And it comes as a great concentrate where you get 10 milligrams per 1 ml. So it's quite easy to dose, even in fairly high doses, for people who cannot swallow well anymore. Then there's bone pain, as I said, often from metastatic disease with certain cancers, and both steroids and non-steroidal anti-inflammatory drugs, the NSAIDs, are good for bone pain. Some people get stomach upset with one or the other, and we generally use a concomitant H2 blocker or proton pump inhibitor to reduce stomach acid if people are going to use a steroid or a non-steroidal anti-inflammatory drug on a long-term basis. The non-steroidals are relatively contraindicated when people have renal failure, but again, the risk-benefit ratio needs to be taken into account for somebody who has only a very limited time left. If that medication is very helpful for their symptoms, it might be fine to use a non-steroidal anti-inflammatory even for someone who has renal failure. Next are our medications for dyspnea or breathing issues, whether it's a shortness of breath or work of breathing or feeling of breathlessness or air hunger. Narcotics, again, are the gold standard. We use morphine to help air hunger, and this requires education for patients and family members. We also use benzodiazepines. And these are other medicines that some people might be worried about getting addicted to, whether we're using lorazepam, Ativan, or Xanax, or Librium, or Valium. All of those are good for dyspnea and anxiety. Whether the anxiety is giving the dyspnea or the dyspnea is giving the anxiety, benzodiazepines can be very helpful. They're also helpful for sleep. They're helpful for people who have alcohol withdrawal concerns, any seizure prophylaxis concerns, some of the seizure medications that people may not be able to swallow late in their illness trajectory. If there's a great concern about making sure that we give medications to prevent seizures, the benzodiazepine lorazepam or Ativan is available as an oral concentrate that's 2 milligrams per 1 ml, so you can get a pretty good dose with just a 1 ml solution in the mouth, which a lot of people can tolerate even when they're no longer tolerating pills for seizure treatment. And when we use oxygen, we need to remember that we're not using this to try to make someone's oxygen saturation look good. We're using this if it helps them feel better with their dyspnea. Oxygen treatment is very uncomfortable for a lot of people. It's very drying to the nose when used through nasal cannula. Some people don't breathe well through their nose, so they're going to need a mask in order to get the oxygen into their mouths as well, and that can be claustrophobic for some people. So if people are bothered by oxygen use, don't use it, and it's okay if their oxygen saturation is low, because if our goal is comfort, we're not trying to make sure their oxygen saturation is good. We're trying to make sure that they feel better in terms of their breathing. So when we use oxygen, we may ramp it up to higher levels without knowing what we're doing with their oxygen saturation, because if the patient feels better with it, we'll use it. And on the other end, we may wean people off of their oxygen if they don't feel any worse without it, especially if they feel better not having a mask in place or not having that drying effect of the oxygen always going. We also for patients with end-stage lung disease who've been helped by inhalers throughout their lives. Many people don't use inhalers correctly even when they're at a more healthy state of their disease process. But as people get weaker and older, inhalers get harder and harder to use properly and get an effective dose. So we want to use nebulizers whenever possible. That's just easier to make sure they're actually getting the medication in. And now that we've gotten through most of the COVID pandemic, we don't have so much concern about, having aerosolized nebulizers around for people to use, because that can be of great help for people who need their COPD medications and need to make sure they're getting them in properly. There are also some people that have just very thick secretions, and as they get weaker, they have more trouble coughing them up. They may not be able to tolerate the relatively high volumes of things like Robitussin or other mucolytics you would use to try to thin out those secretions. They may not be able to drink a lot of fluids to stay well hydrated, which might help with those secretions. So one of the things that you can nebulize is just plain saline, and saline nebulizers a few times a day can sometimes really relieve that, stuck phlegm in there. So consider that as a possibility. Next, we'll talk about medications for agitation. And again, as we've discussed before, we want to talk about what's actually causing the agitation. If they're agitated because of pain, then you want to use a pain medication for that. So if they're grimacing or moaning, especially if you touch them in certain areas where you know that they would have pain from their disease process, then try a pain medicine first for that agitation. If they're anxious, then try treating that agitation with a benzodiazepine rather than, say, an antipsychotic if their agitation is because of hallucinations or delirium. If they're constipated, we've got lots of medications to treat constipation, and we can use, suppositories or enemas if people aren't able to take oral medications for constipation. We want to be really on top of constipation when people are using narcotics regularly for pain. We should assume that someone who's going to need a narcotic every day for pain is probably also going to need a medication for constipation every day. If they can't take something like Miralax every day, which is a fair amount of liquid to have to swallow, then, Senna comes as relatively small tablets that can be crushed, or it comes as a liquid that people might be able to tolerate better. Lactulose, despite being very syrupy and not the taste everyone wants, tends to be really effective at a relatively low dose for constipation. And then, of course, you can use things like Dulcolax as a suppository when you can't get enough things in from above to treat constipation. Urinary retention sometimes can be caused by some of the medicines that we're using. Some of the anticholinergics that people get on are the first things we should get rid of, as if at all possible, when people get on to hospice. So some of the medicines that were used for people at urinary incontinence might end up giving them retention, and we should stop those medicines if at all possible. If there's nothing that they're taking that were their previous medicines, not even just their comfort medicines for terminal illness, if there are medicines they're on that are anticholinergics, we want to get rid of as many of those as we can before we use other modalities like a Foley catheter. But that a Foley catheter might be needed, especially in those very final few days of life, and make people a lot more comfortable as well. When agitation is caused by things like delirium, with psychosis, hallucinations, especially common in dementia patients, then our gold standard is Haldol or some other antipsychotic. This is what helps them with paranoia and delusions and things like that that are causing agitation. We tend to avoid Haldol in patients who have Parkinson's disease or Lewy body dementia because that may worsen the movement disorder associated with Parkinson's disease. In that case, there are other antipsychotics like risperidone or Seroquel, quetiapine, which can be very useful and also tend to be a little more sedating, especially the Seroquel, which may or may not be helpful when people are having their sundowning symptoms and can't sleep. Something like Seroquel could be helpful to both treat their agitation and the insomnia that may go along with the sundowning process that's common with dementia patients. The reason we tend to use Haldol so often is that it's also available as an oral concentrate that's 2 milligram per ml, so that you can get decent doses with very small volumes of medication if people can't swallow pills anymore. Haldol is also a medicine that we can give subcutaneously in our inpatient facilities, so that we have good ways to help them with agitation, and Haldol, like a number of other psychotics, is also good for treating nausea. So we like to have medicines that we can give to people for nausea that doesn't require them taking something in their mouth. Taking a pill for nausea never seemed to quite make sense to me because they might just throw that right back up. So Haldol has many uses for us in the hospice realm. And when people are at their very final stages, when people have what we would call terminal agitation, where they are in their final days of life, typically, maybe their final week or two, we might need to use a benzodiazepine such as lorazepam or Ativan on top of Haldol to make people comfortable. And again, the benzodiazepines have the added benefit of being good for people who have alcohol dependence, anxiety issues, insomnia issues, etc. Because a number of our hospice patients are still drinking their alcohol at home, even as they die of their alcoholic liver cirrhosis. And so when they get to the point where they can't keep their alcohol down at home, we do have to worry about withdrawal symptoms, and giving them the benzodiazepines instead makes that one less potential source of suffering at the end of life. Finally, I don't want to leave out integrative therapies and alternative therapies for people who need comfort care. Some patients respond very well to alternative medical therapies, whether or not they, quote, believe in, unquote, these therapies or not. Our home health aides and volunteers at Sharp Hospice Care are all trained in healing touch energy work, and some people swear by this as being helpful in terms of treating anxiety as well as some of their pain as well. We offer music therapy, which people love. We don't have much access to pet therapy, but you see that in the hospital periodically, and that is another thing that's just helpful in terms of giving people a distraction and a way to find some calm and peace. Mindful meditation is a big buzzword in our healthcare system currently, and we are encouraging everyone to find ways to meditate throughout their daily lives, whether at work or not. And this can be another way for people to take a step back and out of their process of coping with death and dying, and find strategies to find peace. Massage is helpful for some people, especially with certain pain patterns. Acupuncture may be helpful. Biofeedback may be helpful. So don't forget to ask about what people are already using or what they've found to be helpful in the past. Or whether they have any interest in using alternatives. Don't forget about the spiritual care counseling that might be available through your team. Don't forget about your social workers and potential bereavement counseling services available. In the hospital setting, our social workers tend to work on placement issues and community services, but some of them do a bit of counseling themselves and welcome the opportunity to incorporate that into their services if that's what their patients and family members could benefit from. In the hospice realm in particular, Medicare requires that a certain number of our hours are offered by volunteers. Hospice started as a volunteer organization back in the 60s and 70s, so we still have volunteers who can provide all sorts of services for patients. And we also give bereavement services for 13 months after death. So this is incorporated into hospice as well, whether you had just one day of hospice service or you had a 6-month or 2-year experience on hospice. Your loved ones get 13 months of bereavement services free of charge afterwards. And one final thing about medications and alternatives is ask people about their use of homeopathy or, things like CBD and THC. Those are not federally legal at this point, so they're not things we're able to offer in our inpatient facilities where we are mostly funded by Medicare, which is a federal entity. But you do want to be aware if people are using these things and find them helpful so that you can guide people a little further on their journey and know what works for them. Finally, remember your goal is to comfort always. There is an old saying that was attributed to Hippocrates, but probably is much more recent and has various origins. But it says, cure sometimes, relieve often, and comfort always. So that even when people use words like there's nothing more that can be done. That's never true. There's always more that can be done in the comfort realm. And death is inevitable. That doesn't mean that there's nothing more to do. We want to embrace the teachings of death and its inevitability for all of us and get used to the fact that that's going to come for all of us and that there are ways to get through it without an inordinate amount of suffering. We have so many treatments for diseases, but there are lots of things for supportive care when treatment to restore health is no longer an option. We can always comfort people as they're dying, and we want to plant seeds for future decisions that patients and families make so that they know in the future that it's okay to die. When I was transitioning from my family medicine practice into hospice care, I started telling my patients about 6 months before I left that I was going to hospice care, and a number of them wanted to give me their insights as to their experiences with death and dying as they wished me well. And I'll never forget one man who said, "Oh my, when my mother died, I was the family member that was just such a pain in the butt to everyone on the medical team. I'm sure all the doctors hated me, and I was the one who was always questioning what the nurses were doing. I came from a big Catholic family, and all my siblings were finally on board with letting Mom go, and I was the one who was going to step in and save her and fight for her because I was sure that I loved her the most. And he told me that happened many years ago. And even though he knows that nobody on that medical team thought he learned anything from them about the death and dying process, he really had. That some seeds had been planted, and that he told me, I'll act differently next time. When it's my father's time to go, I won't be fighting it so much. I'll know that there's an easier way to go, and that it is okay to die. So remember, for all those times that you feel like you're planting seeds in a desert and not getting anywhere with educating patients and family members, all that anticipatory guidance is worth its weight in gold and is worth your time in gold, because you are doing a great service by being out there educating people. So thank you. Again, thank you for all you do to help patients and families along their disease trajectory and through the continuum of care. It's quite a roller coaster. I hope that you've taken time to do my knowledge assessment. If you didn't do it before listening to this presentation, then please do it now. I hope you've learned something from this, and we'll have a question and answer session in the future so that we can discuss things further. Thanks again.